Good afternoon, everyone, and welcome to this webinar today, and thank you for joining us. I'm John, the editor at HTN, and for this session, we are set to focus on and discuss delivering innovative new models in community healthcare. And we are pleased to be joined by a panel, and I'm pleased to welcome Nick Cross, the Executive Medical Director at Wirral Community NHS Foundation Trust, Becky Sutton, the Chief Operating Officer at Nottinghamshire Healthcare NHS Foundation Trust, Kumbi, Kariwo, the Equality and Inclusion Project Lead at Birmingham Community Healthcare Foundation Trust, and Peter Hansell, the co-founder at Isla. So welcome to the panel and thank you for joining us. There's just a couple of things to cover before we kick off. So this session is being recorded and will be made available shortly. Along with the HTN team are doing a write-up as well of the key discussion points, so you can read or watch the session back at a later date, and you can share it with your colleagues as well. During the session, we do have time for a planned Q&A. So if you have any questions, feel free to type them into the Q&A section, and towards the end of the session, we'll go through those then. So finally, I'd like to hand it over to Pete, who's going to start with some context and an introduction for us.
Thanks, John. Very excited for this. Hello, everybody. Nice to be on the call with you all, and very excited to be joined by such an amazing panel today. So Jade, if you just flick on, we'll just run through what we're going to cover today. Thanks. So we're just going to talk about what we see at Isla as one of the really key things and kind of mechanisms to improve community care, then move on to how our technology platform supports that, the opportunities that creates across different clinical areas in the trust, and then some of the results that we're seeing across the country. And so if you'd move on. So I wanted to start just with some kind of brief context and I suppose history on Isla. So we launched Isla really, I think, kind of with the motivation that probably is shared by a lot of the people who are on the call today. So quite a personal motivation for wanting to improve our NHS health system. I grew up helping my dad to manage his clinical condition, which is called multiple sclerosis. And I think through that, I think I really developed a very strong sense of the value and how important the NHS is to people who are dealing with conditions like that. And so throughout my childhood, he had a lot of support from acute providers, from primary care, from community care teams, right through to social care, and people who would help him to get showered in the morning and get to work. But alongside that, what became very clear was that actually a lot of that was very disconnected. And so really no single person in that process had a very complete understanding of how he was doing. And so we started Isla really to kind of address that challenge and to create a dramatically better visibility of patients' conditions and the way that they're developing. And so if you would jump on, I'll just kind of talk a bit more through what we mean when we say that. Thank you. So really kind of Isla's technology focuses on the first sort of two steps of the healthcare process. So observation, understanding the symptoms and the condition of a patient, assessing and structuring that information so that we can begin to make the right clinical decision, and then moving on to the kind of treatment plan and the intervention. So I would focus on the first two steps, observation and analysis. And the way that we do that is by connecting up the inputs and the sort of flow of information from a very wide set of stakeholders. So that might be anyone from the patient themselves at home through to their family members who are supporting them, right through to the quite wider community and people like school teachers who might have an input there, and then through into community care and acute care and primary care. And particularly, I think, in the community care setting, that flow of information from not just the clinicians, but from the wider group of stakeholders is really, really essential. So if you move on, I'll just give you a very quick summary of kind of how we do that. So at the top level, there's kind of two real use cases for Isla. The first is that we empower clinicians to capture and structure information when they're delivering care in the home, doing their visits. And so that enables community nurses to very conveniently capture things like images, videos, sound recordings of patients at home. They can also complete all of their assessments, so structured assessments like News 2 or Pubs T or any other assessments that the Trust has in place. And crucially, we focus on doing that very broadly across the community care organisation, so really touching most of the specialties within the organisation rather than focusing just on a specific vertical. And to enable that, we've built a progressive web application which you can access very easily through the browser, but which is also available offline, so that we have that seamless workflow, particularly kind of in more rural communities or in areas where it's difficult to get a connection in the patient's home. So that's kind of use case 1. And then Jade, if you'd move on. Use case 2 is enabling and empowering patients to begin to sort of self-manage, or at the very least to self-report on their condition. And so the way that works is patients and the people who support them, their family members, etc., can receive a link to submit information that comes via email or SMS. They click the link. There's no need to download or install an application. You just follow that through to the browser. Typically, you can complete your sort of data submission flow in less than a minute. And the platform guides patients through the information that we need, how to structure that and how to send it in. We can also do that in the other direction, so pushing advice, instructions, care plan information out to the patient. And the thing that's really exciting there is that we see a very, very high patient engagement through sort of empowering and enabling patients to be a bit closer to the management of their condition. And just to deviate slightly to a really nice anecdote which one of our partner trusts talked through the other day. So there was a patient on the caseload of a trust in the Midlands, 82-year-old man who was managing a pressure sore on his heel. He'd been on the caseload for about a year and was having a visit twice a week from district nursing team. They moved and agreed the kind of shift with that patient that he was going to begin to self-monitor that area of his heel, and he was going to be much more involved in self-care. 2 months in, they'd made much more progress with the healing process for that patient than they had in the whole of the previous year. And the patient was engaged to the extent that when it was no longer necessarily clinically essential for him to be submitting photos and assessment forms every week, he called the trust to say, "Where's my link? I want to keep my clinicians cited on my progress because it's going really well." So I think that's just such a lovely testament to when you give patients the kind of tools and a simple enough piece of technology that they can use, then you can really see quite dramatic improvements in the way conditions can be managed. Jade, if you jump on. Thank you. So back to the platform. The thing that then becomes a real opportunity once we're starting to flow all of this information, both from clinicians and the wider community and from patients, is to begin to join up all of this across all of the different clinical teams who might be involved in a particular patient's care. And so that's where Isla's platform becomes very powerful. We can link up the view and that kind of longitudinal view of a patient's pathway and also their condition across their entire care journey. So that might be something like we can see both historically and into the future when the next message is going to go to the patient. We might be able to see when the next visit is scheduled for, when we're expecting the clinician to capture a set of information and update us. We might be able to see where patients are not responding to those links, and then we can start to intervene. And so really that gives us a much, much better single source of truth and a way to sort of longitudinally understand a patient's condition across the whole MDT. And with that sort of flow of information, then comes the ability to start to look for patterns in that data. So that there's all sorts of examples of that, but where we can start to structure the information to give clinicians that kind of bit of help with their clinical decision making. So we can start to say, you may not have noticed this pattern for this patient, but this is what we're seeing in the data. So that's kind of in a very whistle-stop tour how the Isla platform works. And if you click on, I'll just talk through some of the sort of benefits of that. So I think I think what's crucial to recognise well, probably in transformation really across any part of the health system, but certainly in community care, is that technology is an essential part of that, but it really probably in truth is the smaller part of actually delivering the impact. And so Isla creates excellent visibility of patient condition, but then it's really the trust in the clinical teams themselves that deliver the benefit from that. So what we're seeing and what we're able to measure with our partners is an improvement in decision making. So we can give clinicians a much better understanding of a condition and the way that's changing. That helps them to make more informed decisions. We can improve visit planning. So with the right visibility of the condition, we might be able to plan which equipment we need to take with us, make sure that's a kind of right first time visit. Self-care, we've kind of already touched on. This improved MDT working and being able to gain much more immediate input from specialists is a real value add. So we'll talk a bit more about examples of that in a moment. And then, as is always the case, but particularly now the NHS is under such financial pressure that we really need to be able to measure and quantify the benefits of that and make sure we're saving money whilst delivering better care. So we're seeing a massive reduction in travel, which saves time and money. And there's also a real opportunity then to make sure we're planning for the right grade of staff to be attending for each visit, and to really optimise and help our clinicians work at the kind of best of their ability. If you jump on one again, Jade. Thank you. So the other thing that I think I just wanted to highlight was when we think about transformation in the community, often we jump to wound care because it's such an important and huge part of the caseload. But Isla really, kind of the USP, I think, is that we can work across a massive range of clinical specialties. And so here's just a few nice examples of that. So stroke rehab, we've been able to, this actually in Nottinghamshire, we've been able to connect up that kind of discharge planning process from acute and right through into the community provider, which Becky will be able to talk to. And that saves 30 minutes per patient because we have an understanding, a video-based understanding of the way that patient was in hospital and then right through into the community. In wounds care, we've seen a 75% reduction or de-escalation of same-day demand. That's quite an interesting use case, and we're really excited by this. That flow is places like care homes being able to submit photographs of a patient's condition that they're worried about. That might be a graze or a wound. And then rather than the trust having to respond by immediately sending somebody out because we don't understand how severe that is, we're instead able to review that, give the right advice, the care plan can begin, and then we can do the scheduled visit to the care home when that was already planned. Really nice examples in podiatry, which I'll just jump over in just time. And then dysphagia, I think this is such a nice use case that I can't really skip it. So this is actually Wirral community. This is the speech and language paediatrics team. So they've moved to a model where when referrals come through to their service, the first step is to ask the parent to submit a video of their child. And that's things like infant feeding and those sorts of clinical areas. And then based on the review of that video footage, we've been able to move all of that to a virtual triage model, which saves a lot of time and also allows us to then get the right visit or the right care plan in place much earlier. So just a whistle-stop tour of a few clinical areas. And if you jump on last slide, and then I'll hand over to our amazing panelists. So zooming out a little bit, the impact that we then see at a trust level when we deploy Isla across all of these areas is kind of ticks all of the boxes which are really important for transformation teams, particularly when the NHS is in such a sort of stressed position. So typically we see recurrent financial savings of between £250,000 and £400,000 per trust. We have a very positive clinical impact, and one of the things that gets everyone in the Isla team so excited is kind of working with excellent clinicians and the feedback that we get from them. So this is one in many examples of clinical impact, but we've been able to see a 63% reduction in multiple trusts of the time that it takes to get specialist input for something like a district nursing team. So again, that just shortens the road to being able to get the patient on the right care journey. Environmental impact, front and centre for a lot of us. We saved at Nottinghamshire 27,000 miles of travel in a single year. And then crucially, we need to also make sure that patients are engaged and supportive of the shift. And so we have, on average, across all of our community providers, 92% of patients recommending the Isla platform. And so, in summary, I think the opportunity for community providers is to really move towards a model which not only kind of addresses a pressing need now and helps to free up some capacity in the system and save money and improve clinical outcomes, but also to lay the foundations for what we can do next. So as we start to flow this information into the system in a really structured way, that then gives us the opportunity to move towards identifying the patterns in that and starting to improve care and training and standardization of processes and all of the kind of other areas which ultimately stem from just having a really well-structured information set. So that's it from me. I'll hand over to the panel because I'm very excited to hear kind of their thoughts on what we can do in community care.
Perfect. Thank you, Pete. And it'd be good to go to Nick. Could we come to you first in the Wirral and to dig into your project a bit? But could we start with, could you take us through your role and a bit about yourself? And then what are the key strategies to successfully delivering innovative and digital models in community healthcare?
Okay, I'll certainly do my best, John. Yeah, hi everybody. My name's Nick Cross. I'm a GP by trade. I'm the Executive Medical Director for Wirral Community Health and Care and HSFT. Research and innovation sits within my exec portfolio, which, to be honest, I'm quite happy about. It's something that I've got a real interest in because, Pete, as you mentioned, can make a huge difference to the way in which we deliver services for our population and our communities, and also to our workforce. But B, because it's just loads of exciting opportunities about how we can disrupt the traditional way of providing care and therefore lead to improving outcomes of people by levering those technological advantages, if I can put my teeth in. Wirral Community Health and Care, just a brief overview because it might be helpful to the audience, but it's a community and care FT focusing primarily on a population health managed a based approach to helping people live healthy and independent lives. In addition to delivering a number of consultant-led services and urgent primary care, so your UTCs, walk-in centres, MIUs, we offer a plethora of community-based services too across Wirral, and also children and young people services across 4 out of the 9 places in Cheshire and Mersey ICB, and also from April 2024 across Lancashire. So essentially a huge geography that we're having to now deliver services over. In terms of the key strategies in delivering a digital model in community care, I do have some reflections, so I will do my best. And I think firstly, it's really helpful if digital and innovation agenda is woven into all your trust's organisational strategies and your enabling strategies, first and foremost. To me as an exec, that's something that I've strived to do, and primarily then demonstrates the recognition at the highest level of your organisation that they need to think differently about the way they deliver services, and that digital is going to be a key part in that. So we've got buy-in at the highest level, which is crucial when we're looking at transforming at scale and involving innovation and digital. The second, and I'm sure as many of you like me get loads of emails every week about brand new shiny products, new exciting products, and the benefits that they could bring to your trust. But it's absolutely not practical to be able to follow up on each of these products. It's just not possible. So be very clear about what your trust strategic and operational priorities are, because that's going to help you prioritize what the areas that you want to focus on if you're looking for digital solutions. Once you've identified those, and this is just the way I work through it in my own mind, be really clear then about what the problem is that you want to solve and why. Is it you want to improve the quality of the service, the productivity of the workforce, the accessibility to a service, Or, as Pete, you've touched on earlier, is it to address the green agenda? It may be all of those, it may be a combination of them, but just be really clear from the outset what you want to focus on and what problem it is you want to solve. Because once you've got to that stage, I think then you're at the stage where it's an ideal opportunity to cultivate an innovation mindset. So this is where you know what the problem is. It's an opportunity to bring people together, like-minded people, who to try and attempt to seek solutions to the problems that you're facing. And I would argue that a clinically led and digitally enabled approach is absolutely crucial to this. And for it to be digitally led and clinically enabled actually can lead to a lot of problems further down in the pathway and lead to problems with embedding. But during this phase, again, it's an opportunity for you to sift through the various different options, different technologies, different products, and start to narrow those down, and then take it gather together a really comprehensive project team. So even when people aren't necessarily required at this particular stage, such as procurement or contracting, get them cited right at the beginning of the process. So everybody is clear about what we're hoping to achieve. And then when they are wanting to be involved, they're aware of it, and it's not new news to them. But it's then the time to look at options appraisals about the potential of running pilots to prove the concept. Is it going to solve the problem that we're trying to solve? What are going to be our return of investments? So there's a lot to do at this particular phase, as I see it. And so just don't underestimate it. Don't underestimate the energy that's going to be needed, the drive, the hard work required, because my experience, it's seldom a smooth journey to achieve for something to be embedded. So just be aware of it. And I think lastly, once you've decided on your solution that you want to introduce into a service or an organization, how are you going to embed it to maximize its use and to get uptake? Don't underestimate the challenges of scaling up and behavioral change of getting everybody to use it in the same way across a workforce or a large team. And it may be that you need to consider turning something off in order to force them down a route that you've decided is going to create some good results. And lastly, and again, a really important phase, celebrate success, because if you've got to this point and you've rolled something out, be really proud of yourself, because it's a tricky journey. So make sure you tell everybody about it, get comms involved, and tell other trusts, etc., because it's an opportunity to learn. So in brief, John, if it was brief enough, those are my sort of strategies of how I would look at dealing with something like that.
Perfect. Thank you, Nick. And can we come to you next, Becky, please? Could you take us through your role, your organisation, how you've transitioned to innovation in community healthcare? And can we dig into some of your successes to lead on from what Nick said, and perhaps some of your learnings and advice, please?
Of course, John, and thanks for inviting me again today. So yeah, my name's Becky Sutton. I work for an organisation called Nottinghamshire Healthcare Trust, and I'm their Chief Operating Officer here. Probably one of 3 roles I've had in the 3 years I've been here, really. I think a little bit about our organisation. So we are a large organisation. We offer very similar services to some that Nick around the Wirral, but we're quite contained within Nottingham and Nottinghamshire. So part of our organisation is community health. Again, community services out of all sorts of different sites. We also deliver children's services as well. The extra bit to we've got 2 other bits of our sort of care delivery arms. One's around mental health services. So again, that's for Nottingham and Nottinghamshire Trust. We also deliver forensic services, so high, medium and low secure services, and equally offender health services into prisons. So we started our journey in Notts Healthcare really around the community angle, and Pete's given some examples of some of the work that we've done in Nottingham, but equally I think there's there's some opportunities around technology across all, but I'll focus primarily on community health, although it is in its widest form, isn't it, when you start to look at mental health delivery across that. And I think there's more we can do. We might get on to it later about how we join some of that up. I think we currently in the healthcare system treat physical health and mental health quite separately, and actually they're combined, and using platforms to be able to allow us to do that I think is really useful. In addition to that, I also lead a programme in the system which is really looking at community transformation in its widest sense. So that idea of how do we deliver neighbourhood teams that are built around community assets of local people. And one of the things that Pete identified earlier is where I think Isla's really helped us in some of that journey, or can in the future, is that delivery around self-care, because I think there's no doubting that the demand on community services, the demand on healthcare, generally around an ageing population, comorbidities, health inequalities, all of that thing, is that, we did some mapping in Nottingham to look at, even just some of the specialist care that we provide. If we look at the trajectory of diabetes in a population, for instance, we would never have enough diabetic nurses to be able, the workforce doesn't keep up with the demand. And that's where I think then technology and innovation can come in if we use it in the right way, because it is an enabler. And I think that, Nick talked really articulately about, you have to think of it about how it helps. It won't be the thing that absolutely drives the change, but it can help us think differently around how we can use technology, particularly around driving self-care. And I think therefore then we've got to look at things very differently. Couple of things for me. I think there's some successes around really getting the people that deliver the care and the people that receive the care involved early on in some of that. So that's where some of our successes have led. And I think we were very perhaps we sort of looked at Isla in terms of the product and the functionality that it could do across a whole wide range of services, but we didn't go in at Nottingham around saying we think it's going to solve that problem or that problem. The way we went about it is we engaged a whole load of clinicians on the front line to say, we've got this bit of kit, we think it could be really beneficial to delivering what you want. It does all of these things. How best do you use it? And I think we got some really interesting ideas about innovation by doing that and spending the time, and our clinicians then have sold the product, to be fair, but I think they used it in very different ways than we originally thought. We originally went in thinking, well, it might be able to help with wound care because it can take pictures of pressure ulcers and we can share that with our tissue viability teams. But actually some of the things that Pete identified in the case studies have been things that we never even thought that we could use it for. Triaging patient referrals, the stroke pathway that we talked about, and actually how using those bits of technology can really encourage people along that journey of health improvement by seeing the progress that they've made. I think choosing kit that is not disease specific has always been a real bugbear to me, and a bit like Nick, I can't tell you the amount of emails I get from the amount of different companies selling me the new shiny thing. And I think that's where you have to look around. There's so much technology out there. Actually, you can spend lots of rabbit holes looking at the best solution, and actually what you've got to look at is actually what is the solution that's going to help the majority of patients and can be adaptable and scaled at pace, and cost effective. Because actually if we're buying a different bit of kit for each disease pathway that patients have, the poor patients are going to end up with 22 different devices that they have to log into. So there's something about simplicity for me that I still think we've got more to do within the NHS and globally about how we really do that proactively. And so I think our successes have really been about that clinical engagement that has then sold it, has done all the adoption and the adaption. I think some of the challenges are really around how do you get the financial support for this case of change. Some of these bits of kit are money. But actually, we have to think differently about that. If we're releasing time to care, we have to be really brave to convert frontline posts that often we've got vacancies in. Often we struggle to, recruit district nurses or specialist nurses. How do we take that brave step to say, well, actually, we're going to utilise some of that cash to be able to pay for some of that technology? And I think that's a difficult case. We often get bits of funding for a pilot, NHS Digital, we get bits of funding that help us for a bit, but actually getting those business cases through and being able to articulate the benefits that they have, I think, is a real key. And I don't think we've cracked some of that wholly yet, but we are a way down to be able to at least quantify the benefits and then look at it in terms of investor save. John, I'm conscious of time. I'm going to stop there because I know we've got lots more questions. Does that help answer some of the questions?
Thank you, Becky. That was great, and we can dig into that shortly. Kumbi, could I come to you next, please? Particularly keen to hear about your role as Equality Inclusion Project Lead and how you ensure inclusivity and accessibility.
Thank you. So I'll start off by saying that I'm a learning disability nurse by background. I've worked in the NHS for 22 years. So I started off in children's and families, and more recently, I was the first Chief of Nursing Fellow working with our adult teams. So a real spectrum and just looking at clinical practice. So I'm based in Birmingham, and so when you look at Birmingham, we're the second largest city and very diverse. So right now, when you look at ethnicity, we're now a 50-50 city. We've also got the youngest population if you're looking at cities across England, but also we're also starting to get an aging population. So we've got a real mix when you're looking at our patient delivery. So as part of my role, we look at the Equality Act 2010, and you're looking at the 9 protected characteristics. And what we're looking at is our service fit for purpose? And when you're looking at impact assessments, are our most vulnerable and are the people who aren't able to articulate their need, are we able to ensure that our services are meeting their needs? So I guess for us, when we've been looking at the changing spectrum of the NHS, I think as Becky and Nick have alluded, when you look at staff shortages, one of the things we've said is we can't replace staff overnight, we can't train them overnight. So what working solutions can we put in place? So one of the things that we've done as an organization is we've started to look at quality improvement. So what can we do right now in the immediate future that can impact patients' lives? Because ultimately, healthcare is not going to pause whilst we're waiting, for long-term solutions. And I guess, how do we do things safely? And I think, as has been mentioned before, it's how are you looking at things that are user-friendly? So in Birmingham, we've got 87 commonly spoken languages. So the minute you have an app that has instructions on it, for us, we've already hit a barrier there. So when we were looking at Isla, we actually looked at 10 providers, and we came up with a spec sheet where we said these are our must-haves based on our communities, because these are the things that we're going to need, in terms of functionality. These would be nice to haves, and these are the things that would lead us in rabbit holes if we don't have those things in place. So I think, as everyone has said as well, is that you try to get a solution to meet everything, but what you start to find is that it will meet some needs but not all. For us, our first focus was on wound management, but actually we've now gone into speech and language therapy, into physiotherapy. It's now being used as an MDT tool. So when you're dealing with complex cases, so if someone's English is not their first language and you're asking them to articulate what a wound looks like, actually a picture speaks 1,000 words. What we're having as well, when you look at our skill mix, is that sometimes you'll send a nurse practitioner or you'll send a healthcare assistant out. They will see a wound, they're not too sure. What that meant was we were booking second, third visits with a district nurse or tissue viability nurse. What we now do is they take an image that gets sent through to our specialist teams, they triage it, so you're saving on that travel time. So I guess for us, it's how are we looking at the complexity and bringing in simple solutions? Because I think sometimes we try to, think complex means complex solution, but actually sometimes it's just breaking it down into small little chunks. So I'll pause there again because I'm conscious of time.
No, that was great. Thank you for that. Pete, can we come to you next? So in your presentation, you mentioned the solution has been adopted by a number of trusts over recent years. Could you share some insights into what you've heard in terms of what motivates healthcare professionals and teams in a community care setting to adopt the solution?
Yeah, thanks, John. I think, I think I'll probably just be echoing what everyone's sort of already said. So I think the big drivers are the health system's full of solutions and apps, and there's loads on the market, and we're not the only system to sort of take a special diagnostic approach, but we are one of the ones that has a very wide breadth of application. So, and I think that's crucial. So for digital teams, for IT teams who are managing the implementation, the kind of technical implementation of new technology, the more that you can do with one solution, which gives patients one consistent user experience, the better. So I think that's a really key part of our success. The second is, I think the NHS, probably now more than ever, is just hungry for solutions that work and solutions that you can evidence the impact of. And so to Kumbi's point on simplicity, and then to Becky's point on being able to translate all of that through to actual real life savings, I think we, since starting the business, have focused on that very heavily. And so we have an excellent delivery team who work very, very closely with each of our community partners, and are right in the detail of, how much time we're saving here, what's the change that we're actually going to see, what does that mean financially, can we track it through? And that gives us a really strong evidence base of community partners who've used Isla and been able to actually transact benefits. So I think it's the evidence base that this works and the breadth of applicability that kind of really drive adoption of Isla.
Great, thank you, Pete. Nick, can I come to you next, please? What part of your current community care delivery process excites you, and how do you see it developing over the coming years and the future?
Okay, I mean, from a sort of technological and innovative perspective, I think it is generally a very exciting time to be involved in healthcare in its broadest sense. And when we look at AI, when we look at smart devices, smart dressings for wound care, and then start to merge those with the Internet of Things that people can integrate into their own housing, I think the options here are really endless. And what's good about them is that most of them are aligned to the shift left in care, for care to be delivered closer to home, in or as close as possible to somebody's home. And so I feel that our ability to virtually wrap around people in their own homes in a non-intrusive way is really starting to gain some traction. I think, there is the potential, and I think it was Becky that mentioned it, of having so many different sensors, so many different devices that people have to log in. It becomes a barrier, and actually, it's the key to it is just having the sensors, having that sort of technology in a way that isn't obtrusive, that people don't feel as though Big Brother's always watching them. And there's some really good solutions out there. Access, though, to longitudinal data through different media types and using that to inform a clinical decision is very, very powerful. And, it was mentioned, a picture says 1,000 words. It absolutely does. But rather than having lots of pictures distributed within an electronic care record, and you can't find them, it doesn't mean anything because they're not accessible. So accessibility to that data and that information is really important. And, Isla do a great job from that perspective. Absolutely. So integrating a visual care record, for instance, alongside an electronic or within the electronic patient care record is something that's particularly exciting for us as a trust. And, you know, we've mentioned how we're integrating that into speech and language and dysphagia services effectively, but also access to that longitudinal data, the physiological data, linking that with kettles, with toilet flushes, with mobility monitoring in people's homes, again, is going to allow us to provide a very detailed picture of how people live their lives within their surroundings, and then with the impact of their health, their long-term conditions. So I think we're moving into a really good place where we're able to monitor and deliver care in a different way that makes people feel safe and secure, that somebody's looking at them, and that if there is an issue, it will get escalated through risk stratification models, etc., that are in place. So that, for me, in community in its broadest sense, is really exciting. When we look at children and young people's services, again, so many opportunities for them to remain healthy and active, linking in with their smartwatch data. You know, they're going to be brought up with this sort of information. It's not going to be a barrier to them at all as years pass by. But linking that into electronic care record, again, providing really powerful data, electronic data, research opportunities, you know, are key for that. And then finally, I suppose, automation and AI in clinical decision making is a huge growth area. It's only just in its infancy now, but, you know, in a few years' time, we're going to be looking at things very differently. There's already now a CQC approved virtual AI driven physiotherapy service, for instance. So again, that can enable people, the physios, to concentrate on the really complex stuff, while other stuff can be managed in a different way. So again, lots of opportunities, lots of perceived threats for staff. Absolutely, am I going to lose my job? That's an issue. But often that's not the main driving force. It's about improving care and also improving the experience and intellectual challenge of our workforce by focusing on the more complex cases. So it's going to be a really interesting time over the next 3 to 5 years. And I'll be interested to see what the conversation's like, you know, if we were to rerun this, you know, in 5 years' time.
Me too, absolutely. Well, that was great. Thank you for that, Nick. Becky, can we come to you next, please? Just to drill into your advice, really, for anybody looking at a digital first model in community care. What advice would you give to them?
Yeah, thanks, John, and I'm probably for not repeating myself, but just to try and summarise, I think there's a couple of bits of advice, really. I think the biggest thing I think we've all talked about is, you know, one individual passionate. You need to build that passion beyond your team. So actually, how do you get a group of people that are really, really keen to do something different and be a bit brave? You won't have the answer to everything. You won't have ticked all the boxes when you sometimes start on this. So be brave, have a go. I think start small. So I think there is always, you know, it's a bit of a cliche, but start small with a big ambition. And I think that they're the two bits. So start small in a small area of people that want to do it, you know, and we're probably teaching people to suck eggs around change, but it's the people that make the difference, isn't it? You've got to get people with the passion and the energy. These things are really hard work, and it's really easy to give up when you get one barrier in the way, or, you know, one team. And I always think it's easier to start with the people that want to do this rather than the ones that don't. You will bring them on board ultimately. So start small, bring a team around you that are as passionate as you are. You know, start small but think big. So really think about the opportunities. Be brave about it might not have, you know, hit everything in terms of how you get some of this across the line. And then I think there's that real business sense about think practically about the benefits this is going to have. And Nick talked a little bit really, really articulately earlier around what are the benefits, but start to think about how you build that case for change quite early on, because I think it is those things around, you know, we are cash strapped, aren't we? You know, we really are. But actually how you can sell the narrative to say, actually, we can't recruit all the district nurses in the vacancies we've got, so we're going to use that money a little bit differently in a different way. But you also need that clinical voice to help you do some of that, because a bit like you know, we've already spoken about. People will be worried that we're replacing them with an IT solution. Actually, it's not. It's enhancing, it's enabling the care, it's allowing them to do things that we really need them doing, not some of the basic thing, and promoting self-care. It's back to that bit about that bigger picture, because if we don't get people helping themselves, I just don't think we're ever going to have we're never going to build a workforce big enough. It's exponential in terms of some of those things. So there's some tips from me.
Excellent. Thank you very much for that. So I've got one more question, and then we'll go to some questions from the audience. So if you've got any questions, please type them in. Kumbi, can I come to you next, please? I know you've done some research around wound care for darker skin tones. Could you take us through that, please? And also how solutions can be tailored for diverse patient populations as well, please.
Thank you. So 2 years ago, we started looking at global research, and what we found was that in 1995, Professor Bennett had a call to action to look at darker skin tone, and from that point, no one had actually cracked, the problem. So we started looking at our population group in Birmingham, and so I guess in some ways I went into this naively. As I said, I was coming from children's and families. And so what I think I learned was that you have to be prepared to make mistakes. You have to be prepared to learn. But I think mostly what you need to do is you need to talk to staff on the ground, because what I soon started to learn was that staff actually knew what the pain point was. So what we did was we did a baseline assessment to understand how comfortable and confident our staff were. And what we went on to learn was that traditionally all skincare was based on white skin tone. And so whilst they had some understanding on darker skin tone, there was nothing actually set in our clinical syllabuses and training. So while staff might have applied some techniques, actually we're governed by the NMC. So they were worried about going against regulation in practice that hadn't been yet approved. So what we learned was that actually what we had whilst we were wanting to bring a digital solution was actually a clinical and training problem. So what we went on to do is we went on to work with the national team, so Jackie Fletcher, and we went on to devise a best practice guidance. So that's now available for all staff to download, one of the most downloaded documents. So I'll give an example. So one of the things that you were trained to do was react to red. As much as I'd love to react to red, as you can see my skin, you will never see redness. So you'd probably come and go, Kumbi is low risk, there's no redness. And what you'll then find, so with pressure ulcers, you've got pressure ulcers from stage 1 to stage 4. So in the meantime, my wound is developing. And then when it breaks open, you're like, okay, Kumbi's now got a pressure ulcer. So what we were saying is at stage 1, 2, 3, you probably are seeing indicators, but you haven't been taught them. So what we've been doing over the last 2 years is we're now starting to learn what those indicators are. And I think when it comes to looking at digital intervention, if your current clinical practice is not right, those mistakes follow onto your digital practice. So even looking at AI, so AI is very much, it's machine learning. It reads what you teach it. And so if you're teaching it with errors, it's going to tell you errors. So how are we being careful again in not teaching bias when we're looking at artificial intelligence? So I think that's something we need to be mindful of. I've been on some talks with NHS England, and so there are a number of teams looking at this. And so I know a lot of people are fearful when it comes to, talking AI, but, it's well governed. And so I guess it's how are we having those conversations, those dialogue, because I think staff need to be informed, because when we look at research, they're saying within a few years, 90% of our workforce will be using digital technology to deliver their roles. So those are the types of conversations we need to have. So coming back to wound management, for us, I guess as a nurse, again, when we look at clinical practice, you could end up in coroner's court. I could end up, going through a legal process to justify why I've delivered the care I've delivered. So we very much looked at our solution with a clinical governance hat on. But I think, as Nick rightly said, you also need data. So we tend to have a lot of tech or digital solutions where we input, but actually when it comes to taking it out, it's very much stuck in that, digital ether. So how are we ensuring that the solutions we have allow you to very quickly see the data that you're using? And so I think that's one of the things when I was talking about our spec document, when we looked at Isla, one of the things is that you can see the photos on a timeline. So whether it's 1 week or 16 weeks worth of images, it's very easy to see, compare, and justify. So one of our cases within tissue viability actually went to a coroner's court, and the outcome changed because they were actually able to show the images that they'd taken on Isla, and that actually helped to demonstrate the care that had been delivered. Whereas sometimes what you find is that a lot of clinicians become unstuck when you look at the written record, because that's not always reflective of the care that's been delivered. So I guess so you're looking at your information governance, clinical governance when you're looking at that. Anyway, I digress. So going back into looking at wound management, so what we wanted was a technological solution where we could start to take images of darker skin tone, because what we realized was that we didn't have consent for our photos. So whilst we had a lot of images, none of them were consented. So we couldn't use them for training, we couldn't use them for research. So with Isla, one of the things we started saying from day one was we need all our photos consented for 3 purposes: clinical purposes, research, and AI. So going forwards, patients can opt into what level of consent they're comfortable with. And so in the future, we now have access to be able to use the images that are consented for those purposes. So I guess it's thinking things differently. So going forwards, we've now understood in Birmingham that in terms of our darker skin tone, because it was late identification, we've now changed our pressure ulcer strategy, where now darker skin tone is actually considered a high risk. So anyone who's got dark skin tone within our city now actually has a higher level of scrutiny, because we're recognizing that late diagnosis. But it took a learning journey. And so now our tissue viability team are champions. So they're the ones taking forward. They're going to MDTs. They've actually changed their clinical pathways, clinical flow, because now they can articulate where the pain points were, whereas before they knew it, but they just didn't have the tools to articulate how the change needed to happen. And we're working closely with our integrated care board, and now they're seeing why in some cases our care is reflective in the way that it is. And rather than having, sometimes you go into meetings and you feel you've done your best, but the outcome doesn't feel that way. But what it's done is it's given them the ability to open up dialogue and to work together. So they're working jointly in changing the care. So I think that's also helped in our relationship building between our numerous services, because we are working in a very complex time. And I guess we're all human, and we all want to come in to work to do the best. And so I guess it's how are we giving our staff the tools to be able to do that. I'll pause there.
Excellent. Thank you for that. That was really interesting. So we'll go to some questions from the audience now. And we've had quite a few come in. So I've made a note of them. So if we don't get to them, we'll get to them outside the call. So we've got 7 minutes. The first question is more of a product one. So I'll come to you, Pete, on this one, if that's okay. What type of approach would you recommend to encourage the public to engage with community digital solutions?
Yeah. Very good question, and not a small one. So thinking about this from a product design and sort of UI and UX perspective, I think the big blocker to public engagement is friction. And it's even if you're a very, very tech savvy, tech native person, picking up a brand new piece of technology and understanding how it works and which buttons you're supposed to click and how to log in and register and where, what that process looks like is actually quite a kind of mental burden. And so I think one of the really key things is just to try and streamline and simplify that process as much as possible, which is one of the reasons that we sort of built our flow on the back of like SMS and email technology, because that technology is so well understood and it's been used for so many years that receiving something via SMS, clicking a link, and then being walked through a very sort of simple step-by-step UX is, I think, has been really key to getting good engagement with the platform. So yeah, I'd probably say that's one of the most crucial things, is just simplify as much as possible. The other, I think, is it's easy to focus on the technology itself and not focus on how much communication there should be about the launch of this new process. And so one of the things that more than us, but our trust partners often do really well, is to broadcast that there's a new pathway that's about to begin, that will go on the trust website, that will go on posters and leaflets physically in the buildings. And then we're quite careful with the way that we together script the text message itself. So if it's the first time a patient is engaging with an Isla flow, then that needs to look a little bit different. So it probably needs to give a bit more context and background on who Isla is, why you're receiving text message from us, why this is safe, what your where that data is going to go, why the storage of the data with Isla is safe, what your community trust needs from you, etc., etc. So I think there's, I mean, everyone will say it, but you almost can't over communicate on when you're delivering a change like this, and that's as true for patients and the public as it is for clinical teams.
Excellent, thank you, Pete. Nick.
Thanks, John. Yeah, I absolutely agree with what you said there, Pete. But I think from when we're looking, and that's from a product perspective, but I think when we look at it from a trust and a transformation perspective, any significant change like this, I think ideally co-production and getting some of the patients, some of the service users that are going to be involved and using this, it's an excellent opportunity to really start to understand what's in it from me, from a trust and a staff perspective, but what's in it for me from a trust perspective, and why should I want to use this new device. So again, I would encourage people not to overlook the power of bringing patients into these conversations at a really early stage, because it will help you then spread the message and the benefits that it could bring to other populations too. So I just wanted to add that from a trust perspective, John.
Excellent, thank you, Nick. Right, the next question is, and we have touched on this, I'll come to you on this one, Becky, because you spoke a bit about this. So one of the barriers when we implement new digital innovation is to persuade and guide our clinicians, GPs or trusts to use the innovation. Have you any examples or tips on how to overcome this?
Yeah, I think it's about getting them involved from the beginning, isn't it, really? And then, that bit about how you understand their concerns, their issues around it. So there's something about go out and listen. There's something about use clinicians to sell it to other clinicians. And I think we found that really successful, almost more successful than we expected, Pete. And we've got an example where our nurses went quite live on Twitter about how Isla really supported them and was picked up by Trinidad and Tobago. So I think there's something about clinicians listen to clinicians, and I think then there's something about being really spending the time to listen around concerns, because most people don't want to not adopt technology for a reason, and it may be that they don't understand it may be that they're worried, a bit like we've talked about, what that means for their role. So I think there's something about you really need to go and understand the reasons why they've got issues with it, and then there's something about getting them involved from the beginning, because if they think that it's being done to them, then actually you're never going to get anything done, and we need to do change with people, whether that be patients or clinicians.
Great, thank you, Becky. The next question is on digital inclusion. So Kumbi, could I come to you for this, please? So how have you tackled the challenge around digital inclusion, is the question.
I think it's knowing and understanding your population group. I think it's, what Nick has said, it's talking to our patient service users. I'll give an example. During the pandemic, I got redeployed with 111, and I think we were learning, along the way. And so one of the companies that we were using for images, you had to download it. So you're there talking to a patient saying, okay, what phone do you have? And then you're thinking, okay, I don't have that phone, so I don't even know where on the phone I need to tell you to go to download your app. because they're going, I'm 75. Yes, I have a smartphone, but that's as far as, that goes. So I'm there going, well, you can't then have your GP appointment. And so suddenly your care pathway stops there because of the functionality. So I think if it doesn't work for your patients and your service users, that's where the patient pathway stops. So I think very much co-production and testing it out. I think, if we look at companies such as Google Health, what they're good at is they test. So I think what we need to do, with products, like Isla, is do the same thing. Is, are you testing it? Does it work? And if it doesn't, how are you going to the drawing board? Because one of the stumbling blocks is, oh, that's on our design pathway, but possibly in 6 years' time. Again, health doesn't wait for 6 years. So it's how are we ensuring that with inclusion, it works? But I think the other thing as well, when it comes to affordability or people just not being able to use, if they can't use digital solutions, it's how are we ensuring that we still have that face-to-face contact? So for those that are able to use digital technology, what we're doing then is freeing up time to actually go to those that can't or are unable to. So I think this is how we're marrying the two, in that those that are able, they can use it. Or I think you also increase autonomy. I think, as Pete said earlier, the minute one of the patients was given the ability to. So how many times do we go in at 8 a.m. We've just woken them up, they've had a bad night, and we're saying, right, get up, get undressed, we need to take your image. Whereas like with Isla, you can actually put a week's worth of notifications. So you can say, if if 1 p.m. is the time you get undressed, take the images then. And what you'll find is you get better compliance because it fits in with their routine rather than us trying to say no, because this is the only time we can make, this is when you have it. Because I think what we then have are people not opening the doors to us because we're not fitting in with their lifestyles. So I guess for me, inclusion is thinking, with our patients in mind, rather than saying no. The patient has to think with the service in mind. I guess sometimes it doesn't always work that way, but I think we need to start thinking that way.
Excellent, thank you. And we are up on time, I'm afraid, so I'm going to have to close the session here. If anybody's asked any questions, we will make a note of those and come back to you outside the call. I just want to say thank you to the panel for joining us. It's been a pleasure to hear about your projects, and it's fantastic to hear about them. So thank you for taking the time to come and talk about those. And as well, thank you to everyone who's attended today. The session has been recorded. There'll be a write-up as well, so you can read or watch it back at a later date if you want to. So thanks again, everybody. I'll close the session here and have a nice day. Take care.